Welcome to my Critical Care Shock Lecture Series. Today we'll be talking about shock introduction, we'll review diagnosis of shock, we'll spend considerable time on venous return and cardiac output, as well as oxygen balance. We'll briefly cover some shock monitoring and assessment, and then we'll close with some shock classification and their hemodynamic profiles. Before moving forward, my name is Bob Gibson. I'm an acute care nurse practitioner. I have no relationship with the industry, and I have no financial disclosures to report. Shock is a life-threatening syndrome. In fact, it's the last stop before death. Now, that may sound a bit comical. It's important to stress. Astute identification and rapid intervention are vital to your patient's survival. Shock is common in critical care, septic shock being the most common, followed by cardiogenic, and then followed by hypovolemic. If I was asked to define shock, I would define it as a clinical expression of circulatory failure manifested by inadequate cellular oxygen utilization and tissue hypoperfusion. But what about the diagnostic criteria for shock? How about hypotension? No, shock should not be defined by blood pressure. Actually, hypotension is a late marker of critical hyperperfusion, and we know that you can be in shock and not be hypotensive. This is referred to as cryptic shock. So it's important that we're searching for clues and suggestions for cellular oxygen deficit and hypoperfusion. So we do this by a combination of clinical assessment, laboratory markers, and hemodynamic profiles and findings. With that said, let's explore some cardiovascular physiology. Traditionally, when we discuss cardiac and hemodynamic physiology, we start with cardiac output and the arterial system. However, this educational practice may be dogmatically incorrect since cardiac output is governed by venous return and inflow. So with that said, let's take a look at the venous system and review some pertinent discussion points. So unlike the arterial network, the venous network is a capacitive system with high compliance. So to me, that means that venous system stretches, it engorges, it's able to increase its intervascular volume under relatively low pressures. And in fact, the venous compliance is 40 times greater than arterial. And then impressive, the venous system carries 70% of the total blood volume in the body. And of that 70% of total blood volume, 70% of the venous blood is actually in the splenic vascular bed. So the majority of the venous system is actually a blood reserve. This mentioned blood reserve is defined as unstressed volume, which we will discuss in future slides. Now let's discuss venous return. Venous return is the flow of blood from the periphery back to the right atrium, and it's comprised of three things. The mean systemic filling pressure, you can think of this as the forward pressure that drives flow back to the right atrium. The right atrial pressure. For this example, you can think of the right atrial pressure as the backward pressure against venous return, and lastly, the resistance to venous return. We can also look at this in the mathematical equation, where flow equals the change in pressure. In this situation, pressure 1 minus pressure 2 divided by resistance. So let's plug in our situation to this equation. Mean systemic filling pressure minus right atrial pressure divided by the resistance of venous return equals venous return. Let's break that down into a bit more digestible content that's applicable to the slide that we're discussing right now. And I can do that by saying this: healthy hearts suck and bad hearts blow. A healthy heart, a healthy right heart, has a strong right ventricular systolic contraction in which blood is ejected, followed by a good relaxation period of diastole. During this diastole, this relaxation, this lithotropic period, the RV is able to actively fill. For all intents and purposes, this is causing a suction. It's sucking blood into the RV from the right atrium, from the caval system. Now let's talk about a sick right heart. So a sick right heart either has poor contractility and or has poor ability to relax. So in this situation, the RV might not be contracting appropriately, and it's also not relaxing appropriately. So the right atrium has to build its pressure and actually blow blood into the right ventricle. This causes a back pressure in the right atrium, increasing the right atrial pressure, thus decreasing venous return. Let's show some examples. If our mean systemic filling pressure is 10 and our right atrial pressure is 1, this gives us a gradient, a difference of 9. This should relate to a good venous return. Now let's take a mean systemic filling pressure of 14 and let's elevate our right atrial pressure even further to 11. Now we have a gradient of 3. Mathematically, you can understand how this would decrease our venous return. In addition, we have to consider the resistance to that venous return. This could be increased due to extramural reasons, that is, outside venous pressures pushing in, causing narrowing and increased resistance. Examples of this would be interabdominal hypertension or even a gravid uterus. Venous return resistance could also be seen in the fashion of venoconstriction, and this could be from the sympathetic nervous system and or from catecholamine release. Before moving forward, a basic conceptual point needs to be made. Venous return must always equal cardiac output. With the exception of a few beats, venous return volume needs to equal cardiac output volume. You can't have a 2-liter venous return and expect a 4-liter cardiac output. Let's take a deeper dive into understanding venous return. Venous return is sometimes taught via the traditional bathtub model. Let me explain. Let's take a look at this graphic together. We have a bathtub. Yes, an unusual bathtub. Instead of the bathtub drain being at the bottom, it's at the side. The bathtub is filled by the faucet. Now at the top of the faucet, let's think conceptually, this is our LV, this is our aorta, and then coming down the faucet itself, these are our arteries. The fluid coming out of the faucet, think it is coming into your capillaries and your venules, and then the blood drops into the bathtub, and that fluid, that blood in the bathtub, is your venous blood volume. As mentioned, our drain is on the side. That drain pipe would represent our vena cava, and on the other side of this drain pipe would be a secondary drain reservoir. This would represent the right atrium. So again, we have the bathtub with the fluid representing the venous blood volume. We have the drain pipe representing the vena cava, and we have the right atrium being represented as a secondary drain reservoir. If we drew an imaginary line across where that drain was positioned, we could get a good conceptual understanding of what fluid would drain into the drain pipe going into the secondary reservoir being the right atrium. We also could understand what fluid would not be drained into the right atrium, and this would be referred to as unstressed venous volume. This is venous volume that is not contributing to the patient's venous return or, for that fact, the cardiac output. One could also understand that the volume that is being pushed through that drain could be called the stressed volume. In this example, you can see that the mean systemic filling pressure is much higher than the right atrial pressure, causing a gradient. This causes a pushing or a driving pressure for that stressed volume to be pushed through the drain pipe into the secondary reservoir or the right atrium. This would be an example of pressure 1 minus pressure 2 to cause a large gradient. Now, how about the venous return resistance? If we were still referencing plumbing analogies, the drain pipe is the vena cava. If the drain pipe is open, there's going to be free-flowing fluid. However, if my wife's hair becomes all clogged up in that drain, it's going to increase the resistance to the fluid coming through the drain, and it's going to decrease the flow. Here's a schematic drawing of the same example, the bathtub model. I do like how this schematic actually gives a better representation of the pressure gradient between the mean systemic filling pressure and the right atrial pressure, causing the pushing, the driving pressure of that fluid to go through the vena cava into the right atrium. Let's show another example of the importance of this gradient to cause a driving pressure to get the fluid through that drain pipe. Here you can see a high mean systemic filling pressure and a low right atrial pressure. This causes a large gradient, and you can see from the graphic that that blood above the drain pipe would be draining into the right atrium. Now let's have an episode of an acute blood loss event. Here the blood venous volume reservoir has actually dropped. This lower mean systemic filling pressure drops a gradient between the filling pressure and the right atrium, and this causes a reduction in venous return. So now let's discuss cardiac output. What's a good definition of cardiac output? It's the amount of blood that the left heart pumps throughout the body in 1 minute. It's described in liters per minute. At rest, we range between 4 to 8 liters per minute and average around 5 to 6 liters per minute, and that really depends on your body size. With that said, we should discuss body surface area. So body surface area is a calculation that takes the cardiac output and considers the patient's height and weight. After a body surface area is calculated, we can then calculate a cardiac index. And a cardiac index is just that. It's a cardiac output that's indexed to the patient's body size. When we look at cardiac output, we need to discuss the formula. Cardiac output equals heart rate times stroke volume. We will further discuss heart rate in the next slide, but for right now, let's look at stroke volume. What's a good definition of stroke volume? Stroke volume is the volume of blood ejected from the ventricle in one systolic contraction. As promised, let's take a better look at the heart rate. From looking at this formula, cardiac output equals heart rate times stroke volume, it's very easy to understand. As the heart rate drops, your cardiac output will drop. Let's have a few examples of this. Our first example has a patient with a heart rate of 40 and a stroke volume of 60 that would calculate a cardiac output to 2.4 liters per minute. Now let's take that patient's heart rate and let's double it. We'll increase the heart rate to 80 beats per minute, maintain the stroke volume at 60 mLs. That increases our cardiac output to 4.8 liters per minute. So you can see as you double the heart rate, you actually doubled the patient's cardiac output. Another example here may be a hypovolemic patient. Heart rate is 60. Let's say the patient's on a calcium channel blocker or beta blocker, and this blunts the patient's compensatory tachycardia. So we have a heart rate of 60 and a very reduced stroke volume of 40 mLs. This equates to a cardiac output of 2.4 liters per minute. Now we take that patient again and we administer volume. The patient's heart rate maintains at 60 beats per minute, and the stroke volume increased by 10% after giving the fluid. This would be the definition of a fluid responsive patient, increasing stroke volume by 10% after a fluid bolus. However, this only increases the stroke volume to 44. So a heart rate of 60 times a stroke volume of 44 only increases our cardiac output 2.64 liters per minute. So as you can see, generally changes in heart rate are more important at producing bigger changes in cardiac output. But unfortunately, there's always limitations to some rules. This next slide says 1,000 words. As you can see, the heart to the left has a very controlled heart rate around 74 beats per minute. There's sufficient time for a good, effective contraction followed by good diastolic relaxation of the ventricles, allowing for passive filling. However, the heart to the right has a severely elevated heart rate. This shortens the length of diastole, the time that the heart is able to relax and passively fill, and this actually decreases the ventricular filling time, and this can result in a decrease in stroke volume. Let's talk a bit more about stroke volume. Recalling that stroke volume is the volume of blood ejected from the ventricle in one systolic contraction, we can further mechanically explain it with the formula of stroke volume equals end diastolic volume minus end systolic volume. End diastolic volume is a preload dependent variable. This is the peak relaxation and filling of the ventricle. Next is the end systolic volume, and this is a contractility dependent variable. This is the peak systolic contraction. In the example in this slide, you can see the end diastolic volume of 120 mLs at relaxation and an end systolic volume of 50 mLs at peak contraction. This leaves a difference of 70 mLs, so your stroke volume is 70 mLs per beat in this example. Stroke volume has three components: preload, contractility, and afterload. Preload can be defined as the stretch of cardiac myocytes prior to contraction. Contractility is just that, the contraction of the heart, the shortening of the cardiac myocytes. And then lastly is afterload. Afterload is the load against which the heart must contract against to eject blood. When we discuss preload, there's many variables that go into it, including outflow resistance, heart rate, ventricular inotropy, ventricular contraction, inflow resistance, venous return, ventricular compliance, and lastly, atrial inotropy, so atrial contraction. Contractility is the inotropic state of the myocardium. Variables that affect contractility is sympathetic activation, catecholamine release, afterload, preload, and heart rate. And lastly, afterload. The variables that go into afterload could be wall stress of the ventricle or the vessel, the aortic pressure, and systemic vascular resistance. With all this talk of stroke volume, let's discuss the Frank-Starling curve. On the graph, you'll see stroke volume on one axis and left ventricular end diastolic pressure on the other axis. And briefly, what Frank-Starling curve is telling us, is teaching us, is as the myocytes increase their stretching, there's an increase in contractility. So with that said, the greater the left ventricular end diastolic pressure, the more the myocardial fibers stretch, the greater the stroke volume is. While not entirely accurate or applicable, I always use the analogy of a balloon when I'm talking about Frank-Starling's curve. If I take a balloon and put 3 puffs of air in it, release that air, let it blow in my face, and measure the volume, compared if I were to take a balloon and blow 5 puffs or 10 puffs into it, and then let go of that air and feel the volume, there's going to be an increased volume in the balloon that I blew 10 puffs in compared to the one that I blew 3 puffs in. So let's explore the Frank-Starling curve a bit here. Right now we have a patient with a left ventricular end diastolic pressure of about 4. Normal's around 8. And with that, you can draw a line up to the stroke volume amount and see that you're getting somewhere around in the low 30s for a stroke volume. Now let's give a volume bolus and increase this patient's left ventricular end diastolic pressure to 8. With that, we now have a normal stroke volume. So a left ventricular end diastolic pressure of 8 gives us a stroke volume somewhere in the high 60s. This puts us into a normal operational range. Let's say clinically you noticed an improvement in the patient's hemodynamics and you decided to give another fluid bolus. So now this increases the left ventricular end diastolic pressure to about 13 or 14, increasing the stroke volume to somewhere in the low 80s. Then you made a poor decision to give even more fluid, and this increased the left ventricular end diastolic pressure around 16, and you had barely any movement in the stroke volume. I would like to recap our interventions. Here we had a severely hypovolemic patient that we gave volume to, and notice the abrupt improvement in the stroke volume with just a little bit in increased filling pressure. Now you gave another fluid bolus, and yes, this did increase the stroke volume, but not to the increased degree that your first bolus did. And now you erroneously gave yet another fluid bolus, and with that increased filling pressure, you barely got any bang for your buck for the stroke volume. So there is a limiting factor when we're exploring the Frank-Starling curve. The left ventricular end diastolic pressure goes up, and we increase stroke volume until it does not. And it's important that we're evaluating this, at least conceptually, on our patient when we're doing volume resuscitation. Now let's explore what the heart's contractility or inotropic state does to the stroke volume. Here we'll explore a constant left ventricular end diastolic pressure of about 8. And we'll plot that to a normal heart, and that gives us, as expected, a normal stroke volume in the high 60s. Now let's take that same filling pressure and apply it to a heart that has less inotropy or less contractility, and you can see the abrupt drop in the stroke volume to a little less than 50. Now let's apply the same pressure to a hyperdynamic heart, that is a heart that has a positive inotropic state. Under the same constant filling pressure with the left ventricular end diastolic pressure, you now have a stroke volume in excess of 80. Now let's overlap our Frank-Starling curve and our venous return curve. On one axis you see cardiac output and venous return. On the other axis, you see a multitude of variables, but most important to point out is the right atrial pressure and the mean systemic filling pressure. And after staring at this venous return curve, you'll realize that venous return increases when right atrial pressure decreases. However, this is only to an extent, as you'll notice with the flat venous return curve at the very top. The reason why that's flat is that the right atrial pressure only can drop so low until the venous vasculature actually collapses and there's no further venous return. And lastly, if you take a look at that big black dot, that's the equilibrium point. This is where the venous return must equal cardiac output. Let me give you an example here. As I increase my right atrial pressure, that decreases my venous return. So the equilibrium point needs to also follow suit. So this will drop my Frank-Starling curve, thus decreasing my cardiac output. Let's give another example here. We'll do a hypovolemic state. First, go ahead and take a look at the overlap Frank-Starling curve and venous return curve. The dotted lines in red and blue are the normal patient right now. We have essentially a filled up bathtub. We have a mean systemic filling pressure of 12 and a right atrial pressure of 3. That gives us a gradient of 9. There should be no issues with venous return at this time. Now the patient acutely bleeds, and hypovolemia decreases stressed volume. This reduces our mean systemic filling pressure. So now our mean systemic filling pressure is 6, and our right atrial pressure is 0. This drops a gradient to 6. And by viewing the graph, you see there's a drop in venous return, and the equilibrium point also needs a drop, so cardiac output drops as well. Next, let's move on to oxygen balance. We cannot discuss shock without having some discussion with oxygen balance. And really everything we do in the ICU resolves around balancing oxygen. That is, always ensuring that oxygen delivery is higher over oxygen consumption. We do this obviously when we're managing shock, when we're taking care of a neurologically injured patient, or a cardiac patient, whether this would be a myocardial infarction, or maybe you're balancing the risk benefits of increased myocardial oxygen consumption when it comes to certain vasoactive therapies. This could even be in regards to acute kidney injury. Acute kidney injury affects about 30% of all our patients in the ICU, and the majority of them are an ischemic acute kidney injury. Before moving forward with discussing oxygen balance, we need to discuss oxygen content and delivery. Oxygen content, CaO2, equals 1.34 times hemoglobin times SaO2 plus PaO2 times 0.003. The first portion of that equation is hemoglobin-bound oxygen, and you'll see that's the majority of our oxygen in our body, about 97% of it. The second part of that equation is oxygen dissolved in our plasma, and that's about 3% of all the oxygen in our body. We take the result of our oxygen content formula, and then we also plug it into our oxygen delivery formula, which is oxygen content times cardiac output. So complicated formulas aside, what really matters in this formula? And that would be hemoglobin, SaO2, and cardiac output. In day-to-day ICU management, we would ensure an adequate hemoglobin level, an adequate oxygenation level, and then appropriate cardiac output, and that would involve looking at our preload, contractility, and afterload. So if there's oxygen delivery, there's obviously also oxygen consumption. Oxygen consumption is 1.34 times hemoglobin times SVO2 plus venous oxygen times 0.003. We take that sum of the formula and plug it into our oxygen consumption formula, which is arterial oxygen content minus venous oxygen content times cardiac output. Again, what's important in this complex formula? Obviously, there's a direct relationship with hemoglobin, but more importantly, in this oxygen consumption formula, the relationship between the difference in arterial oxygen content and venous oxygen content. In addition, our cardiac output. In future lectures, we'll discuss the various types of shock and how we're going to treat those, and that will really focus on oxygen delivery, on improving oxygen delivery. But how do we improve oxygen consumption? What could be some examples? So in appropriate patients, we could treat fever. We can take care of piloerection, shaking, or rigor. We can treat work of breathing, pain, agitation, anxiety, control seizures, and also monitor and treat hyperdynamic states. Because the goal at the end of the day here is to have a reserve, to have a ratio of oxygen delivery and oxygen consumption that ensures a reservoir for the patient. With that, we can calculate an oxygen extraction ratio, and this is oxygen consumption divided by oxygen delivery. In a resting state in a healthy individual, our ratio is 5:1. That's 5 parts oxygen delivery to 1 part oxygen consumption. This should really hit home in understanding and how much of a physiological oxygen reserve there is in the body. And again, while I only really want you to understand the conceptual understanding of all these formulas, we can actually calculate them. In this example here, a static resting oxygen consumption in a normal person is about 200 mLs per minute. Is about 200 mLs per minute, where the average normal oxygen delivery is about 1,000 mLs per minute. And you can see with the formula here, we come to 0.2, which is 20%. That would make this patient's DO2-VO2 ratio to be 5:1. And lastly, we can loosely associate a SVO2 around 70 to 80%, that we're dealing with a normal oxygen extraction ratio. I do feel compelled, though, to state that there is limitations in using a SVO2 in this manner. Next, I would like to discuss the oxygen dissociation curve. As you can see, at one axis, we have the oxyhemoglobin saturation, and then the other axis, we have a partial pressure oxygen. I'd like to discuss the 30-60-90 rule. And what that states is that under normal conditions, a PaO2 of 30 will relate to a oxygenation saturation of 60%, where a PaO2 of 60 will plot to an oxygen saturation of about 90. A second point that I would like to make is all the action, all the business is at the line plots. Everything under that should be looked at as an oxygen reserve. Next, let's pay particular attention to a PaO2 of 60. There's near maximal saturation at a PaO2 of 60, around a saturation of 90. Further increases in PaO2 only modestly increase the sats. The other thing to point out is the other side of PaO2 of 60. Also, as soon as a PaO2 drops below 60, there's a rapid drop in your saturation. And then the last thing I want to discuss with the oxidation dissociation curve is a shift to the right, shift to the left. What are we talking about here? The heavy red line is a normal state. A shift to the right is in blue dotted line. A shift to the left is in the green dotted line. When we shift to the right, there's reduced affinity for oxygen. What does this mean to me? It means the hemoglobin is more readily able to get rid of the oxygen, let go of the oxygen, whereas you have a shift to the left, the hemoglobin is hugging onto that oxygen and not letting it go to the tissues and cells as easy. So when might you have a shift to the right? A fever or acidosis. Now, I find this remarkable. Your body's so smart that it knows when it's ill, it has a fever, you might be acidotic, that it is actually going to release oxygen and improve your ability of your tissue and your cells to receive oxygen from hemoglobin. The polar of this would be a shift to the left. So this could be a hypothermic patient, this could be an alkalytic patient, and then I also want to point something out being decreased 2,3 dBg. So what does 2,3-DPG mean and what is its significance? This is a salt that sits on the hemoglobin. And the clinical contents that this applies to is blood transfusions. We generally give blood transfusions with the thought process that it's going to increase oxygen delivery. However, stored blood has decreased 2,3-DPG. So with that, stored blood can shift us to the left, reducing the ability of the hemoglobin to let go of oxygen to the cells and tissue. Now let's move on to monitoring and shock. And this really includes clinical exam, basic monitoring, laboratory values, and lastly, hemodynamic monitoring. Now we're going to have a whole separate lecture on hemodynamic monitoring, so that won't be included in today's webinar. Let's go over some exam and findings of a patient that might possibly be in shock. And to me, the first thing that comes to my mind, no pun intended, would be mental status. There's a decrease in blood perfusion, the brain is hypoperfused, and mental status is one of the first things to change. I can see differences in my pulses. I may see hypotension. Again, do not use hypotension as a diagnostic marker for shock. I might see findings of cardiac ischemia, either on an EKG or a troponin leak. I might see arrhythmias. I could see a tachypnic patient. Tachypnea is the number one vital sign of critical illness. It throws red flags that the body is compensating. This might be for a metabolic acidosis. We could see findings of hypoxemia. We could see increased work of breathing. We have decreased gut blood flow. The patient could be nauseous. They could have hypoactive bowel sounds. They could have laboratory findings suggestive of ischemic hepatitis. They could have low urine output. We could see acute kidney injury. It's important to be mindful of skin temperature and characteristics. And lastly, very important to identify early metabolic acidoses. Let's go over two examples. We could have a patient that has a warm shock. We'll discuss this more. They have a warm shock. They're in distributive shock. They're in septic shock. Their hemodynamic profile is suggestive of distributive shock. They are hyperdynamic. They have an increased cardiac output. They have a decreased systemic vascular resistance, and they have variable filling pressures. Now, common things being common, a septic shock patient might also be hypovolemic, so they may have low filling pressures as well. So how will we see this patient at bedside? We'll see a patient that's hot to touch. They're flush because their SVR is low and their cardiac output is high. They may be sweaty. They may have pounding pulses, and they'll have flat neck veins. A complete polar to that presentation would be a patient that presents in cold shock. This would be cardiogenic shock, maybe from an acute myocardial infarction. And then our hemodynamic profile is specific to cardiogenic shock. We have a low cardiac output. We have increased SVR, increased systemic vascular resistance. This is the body trying to fix itself because of the low cardiac output state. And then we'll have increased filling pressures. So what will we see different at the bedside? This would be a patient that would be clamped down with a low cardiac output. They may be cool to touch, demonstrate pallor or cyanosis. They're clammy to touch. They have weak pulses, and they have positive JVD, increased jugular venous pressure. And time again, we're reminded of the importance of assessment of skin temperature and cap refill. Some of this literature goes back as far as 1969, looking at the temperature of the great toe. This concept was actually reinforced in 2016 when they looked at the toe to room temperature gradient. So long story short, what we're saying here is skin temperature is important in your clinical exam. Lastly, cap refill is also important in your clinical exam. It's a marker of understanding the microcirculation and degree of hypoperfusion. In this specific paper, they compared lactic acid to cap refill, using these two as strategies in fluid resuscitations, and they actually found similar outcomes. Next would be modeling. Modeling is yet another important red flag in your clinical exam and assessment. And I'll summarize the literature as modeling is a yellow flag, if not a red flag. Its sensitivity is a little off. I think this is because sometimes it's hard to distinguish whether this is localized microperfusion issues or globally, i.e. shock, or if this is from some other disease process. Regardless, when you see modeling, something is wrong and the search is on. A modeling score has a grade 1 through 5. 1 would be just the tip of the kneecap, and 5 would go all the way up, extending into the patient's groin. Here's some impressive flare imaging. A grade 1 modeling is all the way to the left, where the 5 is all the way to the right. You can see the differences in temperature. This is really highlighting the degree of microcirculation issues as well as hyperperfusion. Next, let's talk about blood pressure. And before moving forward, one of the other important items to discuss and why we can't solely look at blood pressure for shock is looking at this formula. Blood pressure is equal to cardiac output times SVR, systemic vascular resistance. In my most sarcastic example that I could give you, I could show a very low cardiac output with a very high SVR and still get an okay blood pressure. This is yet another reason why we can't just stare at one number, at one blood pressure, to understand if the patient's in shock. So how do we measure blood pressure? We really have three different ways. We have the old-fashioned manual stethoscope blood pressure cuff. This honestly is what I would prefer. But in the ICU, there's no way I'm getting a manual blood pressure every hour, let alone every 5 minutes. So then we default to a non-invasive automatic measurement machine. And this machine does not measure blood pressure how you and I do. It measures it by assessing the degree of oscillations in a blood pressure. There's also many limitations of this type of machine. This could be cuff size, if you under or oversize a patient's blood pressure cuff location. Newsflash, a blood pressure cuff is for the upper arm. Once we start doing squirrely stuff like putting a blood pressure cuff on the wrist or the calf, the degree of accuracy definitely goes down the drain. Patient positioning is also another factor. The patient needs to be supine. And lastly, the habitual teaching is that in a critically ill shock patient, these non-invasive automatic measurement cuff machines may be inaccurate. There's some contention of this teaching in some more recent literature. Maybe this is because there's new evolving machines and technology. We'll have to keep our eyes open to the literature in the next decade on this topic. And then lastly is the arterial line. An arterial line is very accurate. It demonstrates pulse-to-pulse blood pressure and mean arterial pressures. In addition, you have an arterial waveform in which you can do contour analysis. Next, let's have a little talk about mean arterial pressure. If you had a choice between looking at a systolic blood pressure versus a mean arterial blood pressure, you always look at a mean arterial blood pressure. You can see the formula up here. There's many variations of this formula. Here, this is diastolic blood pressure plus 1/3 the sum of systolic blood pressure minus diastolic blood pressure. Looking at mean arterial pressure a bit different, it's cardiac output times systemic vascular resistance plus CVP, which is the right atrial pressure. You can look at our tracing graph over here. This is our arterial wave, showing the characteristic rapid upstroke, a peak pressure signifying the systolic blood pressure, and then the runoff on the tracing demonstrating the diastolic pressure. Everything in that curve, under that curve, is the arterial pressure, and the mean of that would be, yes, the mean arterial pressure. So where do we want the mean arterial pressure to be? And that answer to that is 65. We can look at some literature very briefly. This is the sepsis spam trial. We can also look at the 65 trial. In addition to most recent meta-analysis from 2022, we can summarize these papers by saying there's no difference in mortality by maintaining a standard of care map versus a higher map. A higher map could be defined as a map greater than 70. In addition, we know in vasoactive therapy that if the map is 85 to 80, there's actually more atrial fibrillation. In the same breath, we know a blood pressure that is low is bad. So in this specific paper, these were healthier patients undergoing operative procedures, and the anesthesiologist allowed the map to drop below 55. There was increase in acute kidney injury and increase in myocardial injury events. So this is really a setting of Goldilocks. Too low of a map, bad. Too high of a map, bad. We're looking for just perfect, so we're saying 65. Now, the nurse in me understands how difficult it is to titrate vasoactive to 65. So what's the real teaching here? It's to aggressively wean your vasoactive therapies because we know there's negative downstream effects of running too high of a map while you're on vasoactive therapy. Our next discussion is pulse pressure. What is pulse pressure? It's the difference between the systolic blood pressure and the diastolic blood pressure. Normal is about 40. And what goes into the pulse pressure? Well, one, it's the stroke volume, it's the compliance of the arterial tree, and it's the character of the ejection from the LV. Is it a weak, lazy upstroke ejection out of the heart, or is it very aggressive, abrupt, and steep? Let's look at this a little closer. If we have a narrow pulse pressure, this is generally with a lower systolic blood pressure, we may have a reduced ejection fraction. When I see a narrow pulse pressure, I think this is probably a pump problem. So what's an example of this? A blood pressure of 82/65, that gives us a map of 71, but the pulse pressure is only 17. The arterial waveform below gives you a general characteristic of what that narrow pulse pressure may look like. Now let's take a look at a wide pulse pressure. This is generally with a lower diastolic blood pressure. This is usually in the setting of dilated vasculature. I think this is a pipe problem. This is a vasodilatation problem. So let's take a look at this scenario. We have a blood pressure of 108 over 44. This gives us a map of 65. That's a pulse pressure of 64. The arterial waveform below is a general example of what that situation may look like as well. So this is a great tool to use in our critically ill patients. We see a narrow pulse pressure, time to go get that echo, do a point of care ultrasound, see what their heart's doing. I see a wide pulse pressure. I think I need to tighten up their vascular tone. They probably have a low SVR. The next tool to explore is the shock index. The shock index is the heart rate divided by the systolic blood pressure. This is not a perfect test, but it's to be used in conjunction with other markers for shock. And what's abnormal? Technically, anything greater than 0.8 is abnormal. But if you look at some of the newer emergency department literature, you're led to believe that a shock index more of about a greater than 1 or 1.2 is more significant when we're looking at specificity and sensitivity. And what's an example here? We have a heart rate of 120 and a systolic blood pressure of 98. That gives us a shock index of 1.2. There's high likelihood that this patient is experiencing shock, maybe cryptic shock. But there's limitations to this, and really it goes into discussing sensitivity. Where the limitation I see is that the heart rate response to hemodynamic states isn't the same for all. So elderly might not respond and have compensatory mechanism of a younger person. Febrile states are going to give you an elevated heart rate. That doesn't necessarily mean that you're in shock. Chronic conditions, again, could blunt your compensatory mechanisms. And lastly, if you're on a beta blocker or calcium channel blocker, you're not going to show that compensatory heart rate increase, so you might not have an elevated shock index. But overall, this is a nice tool to put in the toolbox when we're assessing our patient in shock. Now let's talk about lactate. Everybody wants to talk about lactate. Well, lactate is another one of those things that are not perfect, but it's all we have. We use it for a biomarker of cellular hypoxia and dysfunction. And let's jump back to biochem real quick, remembering that pyruvate is a downstream product of glycolysis. And pyruvate really has three fates. One, it's going to be converted back to glucose, or it's going to be converted to CO2 and water. However, under anaerobic metabolism conditions, that pyruvate can't get back in the mitochondria and it's converted to lactate. And just that process in itself favors continued lactate production. Lastly, lactate accepts a proton, hydrogen, and becomes a lactic acid. Now, there's really two types of lactic acid. D-lactic acid, many of you will never be able to test for. We see D-lactic acid in syndromes like short bowel syndrome, where because there's a lack of bowel, there's a lack of appropriate bacteria to break down certain types of carbohydrates, and this results in D-lactic acid elevations. The lactate that you're testing for in your hospitals is most likely L-lactic acid. And with that, there's two types of L-lactic acidosis. Type 1 lactic acidosis is what you're looking for in shock, okay? This is your hypotension, this is your shock, your anemia, your hypoxemia. We also can see elevated lactic acid levels due to exercise, seizures, shivering, and work of breathing. Unfortunately, there's also a type 2 lactic acid, and this really consists of everything that doesn't have to do with cellular hypoxia. And this can be due to a multitude of reasoning. It could be just from systemic inflammatory response syndrome, bad diabetes, some malignancies, folks on TPN with thiamine deficiencies, HIV infections, and lastly, there's a multitude of drugs that can cause a lactic acidosis. One I'll point out here is a beta-2 agonist. On top of this, we need functioning organs to clear our lactic acid. The liver clears about 60% of lactic acid in our body, with the kidneys doing much less. So the toughest scenario that I can point out for you is a patient in very severe shock. They're on high-dose epinephrine, and now they have a shock liver, ischemic liver. So you're going to have a type 1 lactic acidosis from the severe shock, from the severe hypoperfusion and cellular hypoxia. You're going to have a type 2 lactic acidosis from the high-dose epinephrine. And then lastly, you have a shock liver and your body's not able to clear the lactic acid. What does that 1 lactic acid value mean to you? So, like many things in critical care, we don't just look at one number. Everything is about a trend, but we do need to remember there's a multitude of things going into that lactic acid value as we interpret it. One last thing I want to leave you with, lactic acid is not an automatic button for a fluid bolus. Now, yes, the Surviving Sepsis campaign has really pushed us into this mantra-type teaching. And most likely in a septic shock patient, they probably do need that fluid. However, not all shock states or all states of hyperlactatemia need or will benefit from fluid bolus. We need to critically understand and critically think when we see that elevated lactic acid. A low-hanging fruit example would be a patient in cardiogenic shock. That patient might have an elevated lactate, and it actually could hurt them if you give a fluid bolus. Now let's talk about SvO2 and ScVO2. SvO2 is a true mixed gas. It's a mix of the SVC blood, the IVC blood, and the coronary sinus. To draw SvO2, you need a PA catheter, and you draw a blood sample at the distalmost port of that PA catheter that's located in the distal pulmonary artery. This is the most deoxygenated point of macrovascular circulation. This is blood right before it's entering the lung. Tissue and cells have maximally extracted their oxygen. A normal SvO2 is greater than 65%. Now, all patients don't have PA catheters these days, so we use the ScVO2. This is only made possible by an internal jugular or subclavian central line catheter. A normal ScVO2 is greater than 70%. SvO2 and ScVO2s can help understand oxygen delivery deficits and oxygen consumption overabundance, and or both. Another tool that's used infrequently is the venous to arterial CO2 difference. In shock states, there can be a difference between the venous CO2 and the arterial CO2. A normal difference is less than 6. Possible shock red flag signaling would be a venous to arterial CO2 difference greater or equal to 7. To perform a venous to arterial CO2 difference, essential VBG needs to be drawn in addition to an arterial blood gas. Now let's get into the fun. Let's start classifying our shock. We have cardiogenic, obstructive, hypovolemic, and distributive. Some folks categorize shock as cold and warm. Cold would be the shock processes, the shock classifications that have a low cardiac output. This would be cardiogenic, obstructive, and hypovolemic, leaving distributive to be a warm shock. Generally, a distributive shock has an elevated cardiac output. We will have subsequent lectures that will actually discuss each separate shock classification, both their diagnosis, etiology, pathophysiology, and treatment. However, we'll do a very brief review here today. So first, let's start with distributive shock. The hemodynamic profile of distributive shock is characterized by increased cardiac output, a decreased SVR, this would be a vasodilated patient, and variable filling pressures. Some etiologies of distributive shock are listed here. The most common would be septic shock, and then we have anaphylactic shock that is mediated by mast cells. We have neurogenic shock. There's multiple etiologies. The most common would be spinal cord injury. We have inflammatory, which would include SIRS and pancreatitis. Decompensated cirrhosis. We have varying types of endocrine shock. This could be adrenal crisis, myxedema coma, and in addition, the thyrotoxicosis. Thyrotoxicosis is a high output shock. We have vasoplegic syndrome that you might see on some cardiopulmonary bypass cases, and then there's numerous medications and toxins to list. I would also like to sprinkle in a little POCUS, point of care ultrasound. A patient in distributive shock may have hyperdynamic ventricles. The view of the IVC may show a great degree of variation, and then a lung ultrasound would demonstrate type A lines, which would indicate the absence of any water, pus, or blood. Next is hypovolemic shock. The hemodynamic profile is characterized by a low cardiac output, an increased SVR, and obviously decreased filling pressures. There's two main causes of hypovolemic shock, hemorrhagic shock and non-hemorrhagic shock. The first etiology would be skin. An example of this would be burn, and then GI blood loss, third spacing and pancreatitis, specific renal diseases, overuse of diuretics, and lastly, low PO intake. We may see hyperdynamic ventricles with a small left ventricular end diastolic volume. The view of our IVC would show a very small IVC, less than 1 centimeter, with a great degree of variability. And then lastly, our lung ultrasound once again would demonstrate type A lines. Moving on to cardiogenic shock, the hemodynamic profile is characterized by a low cardiac output, an increased SVR, and then increased filling pressures. Etiologies to cardiogenic shock include rate and rhythm. This could be bradycardia, tachyarrhythmias, VT, VF. Next would be acute myocardial infarction, varying types of myocarditis, viral myocarditis, postpartum myocarditis. We could even throw decompensated heart failure into this. Isolated RV failure, any valve issues. I think about wide open MR, wide open mitral regurgitation, cardiac contusion, and lastly, Brash syndrome. This is bradycardia, renal failure, the use of AV nodal blockers, shock, and hyperkalemia. POCUS could demonstrate a multitude of findings, including hypodynamic ventricles, left heart dilatation, isolated right heart dilatation, bi-V dilatation. We could see gross valvular problems via color Doppler. The view of our IVC would show a plethoric IVC. Our lung ultrasound could demonstrate type B lines, which in this case would indicate pulmonary edema. And lastly, additional lung findings could be pleural effusion and a positive spine sign. Lastly is obstructive shock. Our hemodynamic profile is characteristic for a low cardiac output, an increased SVR, and elevated filling pressures. The most common etiologies of obstructive shock would be pulmonary emboli, pneumothorax, and tamponade. Additional etiologies would be abdominal compartment syndrome, constrictive pericarditis, restrictive cardiomyopathies. An example of this would be an infiltrative process like amyloidosis. In addition, we could see autopeep/dynamic hyperinflation. And lastly, LV outflow obstruction from SAM or HOCM. Pertinent findings on our POCUS could be early RA collapse, RV collapse, pericardial effusion. In the setting of massive pulmonary emboli, we could have grossly dilated right heart chambers. In the setting of pneumothorax, we would not see a lung sliding sign, and we may see a lung point. The view of our IVC demonstrates a plethoric appearance. And lastly, I would like to mention undifferentiated shock. It's important to take these undifferentiated shocks and diagnose them as soon as possible so we can understand their hemodynamic profile to improve the treatment regimen. We must also watch out for mixed form of shocks. So what do I mean by that? What are some examples? We could have a septic shock with hypovolemic shock. So this would be a distributive and a hypovolemic combination. We could have a septic shock and a cardiogenic shock. So this would be distributive and cardiogenic shock. We could have an obstructive shock and hypovolemic shock. An impressive example would be a hemorrhagic shock with cardiac tamponade. Another example could be distributive and cardiogenic shock. This could be seen with an ACE or ARB overdose with co-ingestion, beta blocker or calcium channel blocker toxicity. I'd like to close out this webinar with displaying this chart that helps with our classifications of our shocks and also diagnostic findings. Please feel free to email me at any time, and I'll be sure to send over a PDF version of this to your email. Let's wrap up this webinar. First, shock should not be defined by blood pressure. Any attempt to understand shock is pointless if it neglects venous return and its determinants. Oxygen balance management is part of everyday ICU care. We need to take that undifferentiated shock and classify it as soon as possible. We need to understand the hemodynamic profile. And lastly, those hemodynamic profiles assist us with formulating treatment regimens. Thank you for your time and attendance to this webinar. If you have any questions, please contact me at learn@ross-educate.com. Thank you.